Friends, welcome to yet another session of our Young India Intensivist webinars, session number 46. And today's topic is CPR, Cardiopulmonary Resuscitation, which is a very vital topic, I think, and we tend not to take it seriously. And I'll be speaking on it. For the sake of introduction, though you know me, my name is Dr. Tapesh Bansal. I'm a senior consultant in critical care and medicine. And to moderate this, we have a distinguished faculty with us, Professor Moied, sir. He's at Aligarh Muslim University, and he's in charge of the ICU there. And he's a professor and head of the anesthesia department. And more importantly, he's the director of the Indian Resuscitation Council, and even more importantly and more relevantly, he has framed the guidelines, the Indian guidelines for CPR. He's the lead author for the Indian guidelines of CPR published in 2019. So that is, I think, very fortunate, and we thank him for sparing his time, and he will be speaking actively CPR apart from my presentation and giving you all the latest information and insight into this modality of resuscitation, which actually is not developing very well. You know, we are not very successful with CPR, and progress is very slow. So, Chetan, I think I'll request Dr. Moied sir to introduce the topic, and after that we will start. Sir, please.
Thank you, Dr. Tapesh, for inviting me in this webinar on CPR. It's a pleasure and honor for me. As you all know that, hello, am I audible?
Yes, you're audible.
Okay. Actually, this is one of the most important topic in today's, today's management of, any critically ill patients, especially not only in critically ill patients, any patients, because if you see the data, we have around around 3,000 plus, in fact, mortality, cardiac arrest per lakh in India, in fact, and most of them, 60% of them are from for sudden cardiac arrest, sudden cardiac death, and they are all mostly from cardiac origin. And if you see the data as well, that out of this, 90% are they take place in the out of hospitals, primarily in the at home or in the roadside, and only 45% of these patients, they can get an aid. I mean, say emergency medical services to revive them. And if you see the data again, it's only 25% of these patients who are in hospital, they get return of spontaneous circulation, and only 10% of these people out of hospital, they have a return of spontaneous circulation. So naturally, you can see the vital, the significance of this CPR, and especially the techniques, how to go ahead with it, and what to do, when to do, how to do it, most importantly, and then why to do it. So obviously these things are very important for us, and we should always keep this in mind. And it's most importantly the skills which we learn, they are perishable. It's not that you learn it and you just keep it at home and keep it within you. You've got to learn time and again, and these skills are something which is going to make people survive. And especially in COVID times, we have the recent guidelines also for COVID patients, which is very important for us as well. So thank you once again. Without taking much time and being in between you and the audience, Tapesh, I would request you. And Tapesh is really doing a wonderful job, I must say. I would take this opportunity to say that it seems he is independently and individually managing the whole show. And really proud of you, Tapesh, and it's something which you are doing is a very commendable job. I hope you keep this going on, and we have all blessings for you. Thank you so much.
Encouraging words. It is with the support of distinguished faculty and seniors like you and so many others we have in our faculty, and the support and the encouragement from our intensivists, our participants, our audience who are, getting something from our sessions, and that is what is keeping me going, keeping us going. So without further ado, I shall just now start my sharing, and we shall proceed with CPR. So is it visible, sir, the screen?
Yeah, it's visible.
So friends, let us start the session, and I hope we will be able to help you with cardiopulmonary resuscitation, and you'll be much better off at the end of the session. Now, for those of you who have followed the football Euro session, which concluded recently, the Euro Soccer World Cup, there was this sudden cardiac arrest on the going on, and as you can see, they're trying to revive. And the person is he was the best Danish soccer player. I think his name was Eriksson, and he just collapsed. He was not running very fast. There was no vigorous activity, and he just collapsed. And this is an out of hospital cardiac arrest, and the rescue team gave him a shock. They revived him, and today he's well, hale and hearty, but with an ICD, and of course he cannot play soccer. So that is the importance of a successful CPR. Isn't that wonderful? Just look at these guys. One of these guys has just had a cardiac arrest, and they revived him, and he's living a normal life with an ICD. Though, and of course, he has to change his career. So that is the performance of excellent CPR, and that is what we shall aim at. So the history of cardiopulmonary resuscitation goes back to 1750. That is a long time back, and it was first mouth-to-mouth resuscitation in a patient who had drowned, and subsequently in the year, I think 1890, we had the first cardiac massage done, and then it evolved a little, and HA formed its first guidelines in the year 1965, but the outcome was very bad till I think 1990s, 2000, and there was very slow progress, and even today the outcome is not very good. And the work that has been done is not very substantial in terms of giving us concrete evidence. A lot of it is expert opinion, and there are a lot of conflicting data also. So what I'm going to tell you is up to date till this year. This is American Heart Association Guidelines 2020, and this is your European Resuscitation Council Guidelines 2021. So this is all very new, and it's updated. There has not been much of a change, but whatever is there is till 2021. And just to show you our guidelines, Indian guidelines, and you can see this, Dr. Syed Moied Ahmed, who is chairing this. He's the lead author for this, and it's wonderful to have him here. Now, when to start CPR? So that is the key question, and the process of CPR starts when you see a person who has unconsciousness, sudden unconsciousness, and you find him to be unresponsive, and then you have to check his carotid pulse, and if the pulse is not there, you have to start cardiac compressions, and you get 10 seconds for this. As you can see here, 10 seconds. You have not to waste time. The earlier the cardiac compressions are started, the better it is. Survival is time is survival in cardiac arrest. So please remember that if you want to save him, you have to be lightning fast. And at the same time, you should be able to assess the breathing also, look at the chest, whether it's moving or not, and try to assess the breathing. We are all familiar with BCLS and ACLS, so I will not delve into the components of BCLS, ACLS, but yes, all of you should be ACLS certified, and the skill should be well developed. So BCLS and ACLS, if you combine them, this is what we get. Cardiac compression is the first thing that we have to do, and then we have airway patency. The airway has to be open, and then breathing, and then we have to have an IV line, IV access, and then drug administration and defibrillation. So these are the key components of your CPR. Now coming to cardiac compressions. So let me tell you, dear friends, that cardiac compressions is the key to a successful CPR. So much so that there are certain experts who say that you can do only cardiac compression CPR, just cardiac compression CPR. If you're not good at putting in the tube or a LMA, just do the cardiac compression. That also can result in a good outcome many a time. So I have listed the key features of cardiac compressions, and you should be very well aware. So I cannot actually tell you here, how to, what kind of a position you should have. I'm sure most of you know it, but this is very important. The way you do the cardiac massage, the cardiac compression has to be precise. Okay, and when the patient is in the ICU or in the ward, we are going to be talking about in-hospital cardiac arrest. The out-of-hospital cardiac arrest, unlike the West, where they have a proper paramedical team and ambulances equipped, we don't have that system in India. They have automatic defibrillators installed in different places, railway stations, airports, etc. So there is no real point in talking about out-of-hospital cardiac arrest, and most of us deal with in-house cardiac arrest, that is either in the ICU or maybe in the ward, where we have to go as part of the code blue team or the RRT. So key features here are that there should be a hard board under the patient. That is to make the cardiac compression effective, and the recoil should be quick. After compressing, release it, and don't bend and put your weight on the chest of the patient. Don't lean down on the patient's chest. You have to come back, right? And change the rescuer every 2 minutes, because it is tiring. The amount of force that you exert will decrease if you continue beyond 2 minutes. And what about the cardiac output that you generate with good high quality cardiac compressions? It is around 15 to 20% of the normal cardiac output. That's it. It's a very low flow state, even with the best of cardiac compressions. And cardiac compressions, once again, is the key to successful CPR. So get it right, and what kind of a hand position you should have, and how you should do it should be very clear to you. And next, the airway has to be opened up. Sometimes, the airway has blood, vomitus, and other things. The patient may have some debris, so dentures should be removed. And I'm sure you're familiar with this, but don't perform chin lift and head tilt if there is suspicion of cervical injury. You have to go for a jaw thrust. So that should be clear, and OPA should be inserted sooner or later. Now coming to breathing, right? We have started the cardiac massage, the airway has been opened, and now we have to establish some kind of breathing. So rescue breathing in, when there is only bag and mask ventilation going on, is 30:2. That is, you give 30 compressions and then you stop and get 2 rescue breaths, right? But if the patient is intubated or has got an LMA or any supraglottic device, then don't stop the cardiac compressions while giving rescue breaths. And these rescue breaths are given at 6 to 10 per minute. Now, my friends, this is very important what I can tell you here, that the number of breaths should not exceed 10 per minute. 6 to 10 is the key here, and do not deliver too much volume. So do not deliver too much volume, and the breath has to go in gently over 1 second and then release it. So how much tidal volume has to be given? So the tidal volume is around 6 to 7 ml per kg, but that is very difficult to estimate. So how do you decide? So you give a tidal volume which just makes the chest wall rise, right? Now, why should you not give a higher rate or a higher volume? Because what you are giving is positive pressure ventilation. And when you give positive pressure ventilation, your venous return to the heart decreases, the cerebral return, the cerebral venous return decreases, and the flow decreases. The cerebral the circulation, the circulatory flow decreases. So you are having a poor quality CPR. In many studies, it has been seen that the people who are doing the cardiac resuscitation give a higher rate and a higher tidal volume. So this is very important, and this happens because we're anxious and we're trying to save the patient and we don't realize this. So the rate 6 to 10 per minute and a tidal volume is just sufficient to make the chest wall rise. This is very important. Now, the other thing we come to is endotracheal intubation. Now, I've seen many times in my unit and my ICU that people rush for the endotracheal tube when there's an arrest. Now, friends, when a patient undergoes an arrest, a cardiac arrest, he has, oxygen in his body. This is now a state of apneic oxygen. When he goes into arrest, it's known as apneic oxygen. So how long can a patient survive, the brain survive? Because the brain is the most susceptible organ to oxygen deficiency. So it's around 7 to 8 minutes. A healthy patient who undergoes sudden cardiac arrest, right? Supposing he gets a VT, I get a VT, right? I'm a healthy person, I get a VT. So I can survive without oxygen for around 7 to 8 minutes with good cardiac massage, right? So the intubation is not a very important factor here. But definitely, if it's already hypoxic, then you have to go for early intubation. But intubation comes later, or your LMA, or whatever supraglottic device you have. And it has been clearly said and shown in many studies that do not perform intubation if you are not an expert in intubation. Persist with bag and mask ventilation. Persist with bag and mask ventilation, because if you do endotracheal intubation, you are going to stop cardiac massage, and stopping cardiac massage for just a couple of seconds stops the circulation and leads to worse outcomes. So this should be very clear when you are going to do endotracheal intubation, and you better be sure that you are an expert at endotracheal intubation, or don't do the intubation till you get expert help. Okay, so that was about endotracheal intubation, when to do it. Now, the laryngoscopy here should be done without interruption in your cardiac massage. The cardiac massage should be stopped for around just 5 seconds to push the tube in. That's about it. Those are the recommendations. So that is about endotracheal intubation, and of course LMA can be used, and any other supraglottic device if you are comfortable with it. So please do not jump to endotracheal tube. Endotracheal tube comes later. The cardiac compression and bag and mask ventilation is sufficient for a number of minutes for many a patient. I will get them through. We jump to the tube, we cannot put the tube, we don't have ETCO2 monitoring, and we do not know where the tube has gone, and it leads to catastrophe. So we have this cap, which is, I think, familiar to everybody: compressions, airway, and breathing. So compressions is the first thing, and please give high quality, excellent cardiac compression. So we talked about the carotid pulse not being there, and the patient being in cardiac arrest. But sometimes there can be a cardiac pulsation, a carotid pulse, but the patient has a respiratory arrest. This is not so common, but it happens. I'm sure all of you have seen this, and this happens most commonly with drugs. We give overdose of benzodiazepine or fentanyl, or sometimes even aminoglycosides can cause sudden respiratory arrest, or your cholesterol can cause respiratory arrest. So drugs in the ICU can cause respiratory arrest when there can be carotid pulsation, and the other causes can be intracranial events. Supposing you have a brainstem stroke because the respiratory center is in the brainstem, or you have mucus plugging, or you have aspiration, the airway gets blocked. So these are some of the conditions where there can be a respiratory arrest and there can be cardiac pulsation, and then you have to take care of the respiration here. And if the cardiac pulsation dies, then of course you have to take care of the cardiac pulsation also with your CPR. So we have got the CAB going, the cardiac massage going, the airway is patent, and we are giving the rescue breaths with bag and mask ventilation. And in this period, you should have IV access established, and the patient should be hooked up to a defibrillator ideally, or a monitor. And the IV access should generally be a central access. In the ICU, I think many a time the patient already has access, so there's not a problem, but sometimes there is no access. We all know how it is. So try to get an access. If there is an access, there can be some ports or dialysis catheters, they can all be used. And you have your IV line, otherwise a peripheral cannula can be put, and preferably in the upper part of the body. Now, this is showing you intraosseous access. I'm sure you have all heard about it, but I don't think anybody of you has used it. So, intraosseous access is the needle here, which is being drilled into the bone, into the tibia. Tibia is the preferred site. The second site is the upper part of the humerus. Drill it in, and this is done if you are not able to get IV access. And you cannot get IV access. Once in a while, it happens. The patient is going to arrest. There's no IV access. So here you can use intraosseous access. This is recommended by AHA guidelines, and this is a change now from the last guidelines. Last guidelines that recommended that do not waste time if you're not getting IV access. Intraosseous access works wonderfully, but it has been seen in the last couple of years that intraosseous access probably does not provide adequate circulation of whatever you are injecting. So try to get IV access, but of course, if you're not getting, you should go in for an intraosseous access. And the dosing for the drugs for intraosseous access remains the same as your IV access. Now, the other mistake that we make is, I've seen our young intensivists and our fellows and trainees, they often stop the massage to see the pulse and, see the rhythm. So this is a very wrong kind of a thing that we do, because pulse check is not really required initially, right? So cardiac massage has to go on, and every 2 minutes we can just check the rhythm, right? If the rhythm is not changing, you're not going to get any pulse. So the pulse check has to be done as per the situation, and it has to be done when you are doing the rhythm check. That is, every 2 minutes you are changing the rescuer. Generally, you will change the rescuer. So please do not stop the cardiac massage to check the pulse, especially if you are the only one who has started the CPR and the only one who is there. You continue with the cardiac massage till somebody else arrives. So please do not stop the cardiac massage to check the pulse and just waste precious seconds or even minutes or whatever time you take to check the pulse. Now, coming to defibrillation, so the most important thing is your cardiac massage, and now the second thing is defibrillation, as far as survival of your patient is concerned when you're doing CPR. And it has been seen clearly that the faster you defibrillate, the better the outcome. So time should not be wasted in defibrillation, and of course you do not defibrillate everything. It depends on the rhythm, and as shown here in the right, if you see, the success of defibrillation decreases with every shock you give, successive shock that you give. So what do you shock? You do not shock everything. So there are shockable rhythms and there are non-shockable rhythms. So this here is a VT. What we are seeing here is a VT, and VT is, as you know, shockable, pulseless VT or VF. And if you have a pulse with VT, it is an option. You can use drugs like amiodarone, or you can shock a pulse, a VT with pulse. Then this here is a bradyarrhythmia. We do not shock bradyarrhythmias. But pulseless electrical activity or asystole or any other bradyarrhythmia is not shocked. So shocking is done only for pulseless VT and VF, or tachyarrhythmias. There are other tachyarrhythmias also, which are associated sometimes with hypertension, loss of consciousness. There also you can use your defibrillation. So you have to get defibrillation right. It's very important to get defibrillation right. Again, this is a skill. CPR is a skill, and we have to get it right. Unless we get it right, the cardiac massage right, our hand position right, the pressure right, and the technique of defibrillation right, the success goes down. So it is not just you're doing some cardiac massage and you're giving the shock without the correct technique. That's not going to get you the optimal results. So the shock that you give is 200 joules for pulseless VT and VF. And this is a biphasic shock. Most of the defibrillators now are biphasic. Earlier we had monophasic. And sometimes, different machines and all kinds of defibrillators, the machine itself has a recommendation for the shock that should be given for pulseless VT, VF. Now, what is this biphasic and monophasic? So in biphasic, the current goes forward and comes back. That's why it's called biphasic. It is more effective than monophasic, and lesser amount of energy is delivered to the heart in biphasic, and it is the one that you should be delivering rather than monophasic. Monophasic is generally out. Most of the hospitals now have biphasic defibrillators. So when the patient has gone into VTVF and you have recognized the rhythm, do not shock immediately. Do not shock immediately. That is very important. First 2 minutes have to be cardiac massage. This is very important. So you're doing the cardiac massage, and after 2 minutes you check the rhythm. That's fine. It's VT. But if there can be circumstances where you are just seeing that the patient has gone to VT. Do cardiac massage first for 2 minutes before giving the shock. Now, the process of defibrillation involves applying jelly, and you have to press hard. That is very important. Now, that is important because the energy delivered will be less if you do not press hard. Okay, the success depends on how well you deliver the shock. Then, what about synchronization? And what is synchronization? We all know there is synchronization in the defibrillator. You have to press that button. So synchronization is not done for pulseless VT and VF. When we synchronize the shock, what happens is that the shock that you give falls on the appropriate segment of the ECG, right? If you do not synchronize, it's called R on T phenomena. That you're delivering the R wave on the T phase of the ECG, and T is the repolarization phase. So this can actually degenerate the rhythm into VTVF. So if there is a pulse with a VT, then you would synchronize. But pulseless VTVF is almost it's as bad as anything. There can't be anything worse than that. So you do not synchronize this, because in synchronization it takes a few seconds. But all other kinds of defibrillation should be synchronized. And then, of course, you clear all, and after giving the shock, do not look at the monitor, do not check the pulse. Resume massage for 2 minutes. Very important. After giving the shock, do not stop the massage, just start the massage, and at the same time, recharge your defibrillator, because you have shocked the patient, you give the massage for 2 minutes, and then you check the rhythm. Right, and if the rhythm is still VT, then you have to shock the patient again. So do not waste time. The defibrillator should be charging during this period when you're giving the cardiac massage, and the success is best with the first shock. Success is best with the first shock, and if you have a persistent VT, after 3 shocks, around 75% of the patients will respond. And VT is a rhythm which responds well. 50% of the patients of VT respond and are able to survive, at least to discharge. Now, this is the position that you have for your defibrillation, and I think it is quite evident here. On the right side, you go below the clavicle, and on the left side, you go in the mid-axillary right, below the nipple. And there are other positions also. This is not the only position. You can have biaxillary, and you can have the left one going back also. The idea is when you draw a line connecting the two paddles, it should transgress the heart. So that is how it works, because the current then goes across the heart. But this is the one that is most common, and I've told you the other positions also. And in proning, if the patient is prone, you can give the shock with both the paddles in the axillary line. In the axillary line, you can shock if the patient goes into VT. That is very important, because proning, if the patient goes into VTVF, turning him over is like losing the patient. Now, coming to electrophysiology of defibrillation. So you can see here very well on the right, that is the biphasic shock going back and forth. And the shock that you give does damage the myocardium because you're delivering electrical energy and it has current in it. So it does damage the myocardium, and trop will be positive after that. This is important because MI is a common cause of sudden cardiac arrest, right? So trop can be positive. And how it works is that VTVF is actually caused by circulating currents in the myocardium. And when you give this shock, it breaks up these circulating currents. So the VTVF gets broken. That is the electrophysiology of defibrillation. And this is automatic external defibrillator. Those of you who are working in good centers have access to this, and I'm sure you are using this. And this is widely used outside. So this has two pads. You place them just like the position I showed you, and it reads the rhythm, and either it gives you a prompt, you shock, or it shocks itself. So that is an automatic external defibrillator for those of you who may not have used it. So I think I will just now request Dr. Moied sir to give his comments and his pearls of wisdom to our audience. Sir, Dr. Moied sir, your pearls of wisdom.
Yeah, and thank you, Dr. Tapesh. It was an excellent talk, and today I would like to, in this August gathering, I would like to introduce my colleague, my friend, Dr. Rakesh, who is one of the, you can say, stalwart in this, in our Indian Resuscitation Council, framing the guidelines. And he is an additional professor from AIMS. And he has been always associated with us, with me especially, and with IRC. And we have done, collectively, we have done this, framed the guidelines, Indian Resuscitation Guidelines. I would introduce Dr. Rakesh. He's there, if you can see. He's there in the audience. I missed him initially. I don't know whether our chairperson, Dr. Rao, has come in. I'm not sure about him, whether he is there. I could not see him there, though I have requested him to be there with us. But Rakesh is one of the lead author in this, in framing the guidelines. And I would like to share the screen a bit, if possible. Is it possible?
Talk is going on, so we will share when we end. I'm halfway through, so
okay.
Whatever you want to add on whatever I've said so far, and then the end. I've not ended yet. I'm halfway through yet.
Okay. So, so I just would like to add certain things here. In the end, also probably I'll be able to add a few lines in a few more slides. The slides which I've prepared for today's talk. The thing is, as you said, okay, just a sec. Dr. Our chairperson, hello. Okay, you're there. Okay, the chairperson is there. Let me see whether you're there. I cannot see you there in the audience, in the faculty list. So let me see if I can find you there. Is he there, Rakesh? Is he there?
Yes, sir. He's there, sir. He's in the attendee, sir.
Oh, but I've given him a link for the faculty. How did he go inside the attendee? Anyway, if you can share the link, Rakesh, to him, then it's better.
Sure, sir.
Okay. So the point is, very well said, Tapesh. You have really elaborated everything in detail. Not much to speak on this, but then again, I would like to add certain things, which probably will be in addition to what you have said. The one thing is what we in India, if you see, as you very rightly said, the ambulance system is very poor in our system, and if you see the overall literacy level in our country is not that good in comparison to the European countries. And so if you see that 70% of our population are in the rural sectors, rural areas. So reaching an ambulance service is there, and it's just beyond expectation. So we cannot expect that. So what we have, the Resuscitation Council, Indian Resuscitation Council has targeted, aimed, is to every house, every family should have a lifesaver. And with this concept, we came up with a guideline which is compression only life support. You very rightly said that only compression can make a person survive. That's very rightly said. And so we were the first country, you can say, who framed a guideline, means framed an algorithm for people who can, for people who are layperson, who are not that well, that literate, that well educated to understand. So naturally, for them, we framed the guideline, and we have certain characteristic features in our guideline, which I will talk at the end of our session. So one thing is that, so that was our target, and you will be very proud to know that this guideline has been incorporated in the CBSE Class 9 standard, and they have accepted it as a guideline, and they have made it as a topic in the subject of health sciences. So this is one thing which is very new and recent, which I will talk in the later in my end of the session. The second thing is, as you said very rightly, that rescue breath comes later. First is cardiac compression, and high quality CPR is one of the most important things which we are targeting at, and that is what it makes people survive. So high quality CPR can make a people survive, and most importantly, with only high quality CPR, without going for any rescue breath or intubation or ventilation, you can make a patient survive because of the, as you said, apneic ventilation. And the strategy of apneic ventilation is, the physiology behind is that when the patient sustains cardiac arrest, around 1 liter of oxygen is there in his blood. So at least 3 minutes he can do without any oxygen. One thing is this. Third thing is, because 250 ml of oxygen is being needed per minute for the person to survive and the person to survive. So one thing is that means 3 minutes minimum he can survive without oxygen. Second thing is, when you're compressing the patient's chest, you're creating a negative pressure. So when you're creating a negative pressure, if the mouth is open, that pulls in oxygen or air inside the patient's lung. And that is how the patient gets a fresh amount of oxygen. The third thing is that even agonal breath, when the patient is having an agonal breath, or patient is gasping, that can also pull in air. So this overall, you can at least make the patient survive for a period of 10 minutes. And it can be more also if it is not there. If you want to increase it. So this is one thing. The second component, as you said, is cardiac compression. Now, cardiac compression, you were very rightly saying, one thing very important is, now when you're compressing, the speed is, we are making a target in Indian Resuscitation Council. We don't take it as 120, 100 to 120. We make it a fixed target, that is 120, keeping in mind that not to confuse the people, because when you train person, the person starts asking you, sir, 100 or 120, which one to go, or which is 100 to 120. So it is always better that you fix a target that is 120. One. Second thing is that how much depth you've got to press. So that is around at least 5 centimeter depth you've got to press in. So speed is 120, depth is 5 centimeter, and it should have a very good elastic recoil. That means you're expanding the chest to, let the blood come in. Now, this concept of cardiac compression, that means this is a heart, you can say it is a cardiac pump. The concept of cardiac pump is there for a period of 30 minutes. 20 to 30 minutes, this concept persists. After 30 minutes, the cardiac pump it becomes very flaccid. So then it comes the thoracic pump. So thoracic pump comes in, and the cardiac becomes a conduit where the blood goes in and comes out. So the thoracic pumps come in, and because of these two concepts being together combined, they came up with the new generation of cardiac compression, which is an equipment known as the life band, or you can say there's a band which compresses the chest at a frequency of fixed frequency, compressions and relaxes so the advantage of this life band is that you can even transport the patient without which is auto CPR, you can say, without being interrupted of compromising your cardiac compression. So this is very important. So if you are being able to compress the patient at a particular fixed rate and without being compromised, even during transporting the patient, so that becomes very advantage to the patient. So this new concept has come in, and so cardiac compression, as I said, is very important, because you know that relaxation is very important, because at the time of relaxation, your coronary refilling takes place. So cardiac compression pulls the blood out, and when you relax it, it helps the coronary refilling. So this helps the patient, the ventricular fibrillation, the fibrillating heart, because we know that in a fibrillating heart, the heart can survive fibrillation, means all the ATP which is there in the patient's muscles, the heart muscles, that gets wasted around 7 to 10% per minute of not being compressed, going for cardiac standstill. So that means at the end of 10 minutes or 12 minutes, you can say that the patient achieves a flat line or rest systole where you will not be able to have achieved, and the patient goes to a standstill. So that is why it is better that as early as possible, you go for a cardiac compression and defibrillation as well. So the fibrillating heart, as you very rightly said, defibrillation should be done as early as possible. Cardiac compression should be done as early as possible, so that the ATP which is getting wasted, that gets, you can at least supply your oxygenated blood to the muscles of the heart. So that is one very important thing which you have to keep in mind. That means you are losing your time by 7% of the heart it's getting lost. So this is one thing. So compression goes on. The second component is, as you said, breathing. Now let me tell you, breathing has a lot of disadvantage. Very rightly. The breathing is, there's a concept of when you talk about breathing, then you are trying to, you very rightly said that it is preventing your the cardiac, inflow of the blood inside the patient's heart, because you're creating a positive pressure. So over expanding of the chest is really increasing the intrathoracic pressure and preventing the venous return to the heart, and that causes problem in improving your cardiac output. So this is one very important over distension of the heart. One. Second is when you are not being able to ventilate properly, then obviously you can put in some oxygen air inside the patient's abdomen or stomach. When you put in air inside the patient's stomach, because this skill is a very specialized skill, which it's not a ball game for every individual. Unless you have a very good skill learning for intubation, you might fail intubating a patient, and that can cause a lot of air inside the stomach, leading the stomach to distend and preventing the heart to expand. Heart to be compressed possibly. So this is very important. We have to keep this in mind while going for an intubation. So even very rightly said that only bag mask ventilation is adequate enough. If you think you are being able to bag mask a ventilation, so that is good enough. But obviously, when you have a scope, when you're an experienced person, intubation is always preferable. That is one. Intravenous IV line drugs, as you said very rightly, it's something which is well accepted. Defibrillation, obviously, I would add a certain point on this, that keeping in mind that if you go for the studies, if you go on doing a lot of research on this, you'll find that there are a lot of studies which stated that when you defibrillate with a high energy, they say 20 joules, 200 joules, as you said, it is always advisable or better if you have a low joule to start with. You can start with 120 joule. Even the international guidelines also say, and even ISC, Indian Necessity Council, you also recommend that you start with a low joule, keeping in mind the physical characteristics of the Indian population, and secondly, when to defibrillate. Very importantly, you got to keep this in mind, that when you're defibrillating a patient, is always advisable to when you defibrillate when the patient's transthoracic impedance is less. So if your transthoracic impedance is less, then the defibrillation with low energy 120 joule is at par with your 200 joules. But you're at the same time causing less damage to the patient's heart by giving a low joule to start with. So there are studies which have said that when you start with low joule, It is as good as starting with a hydro. So, but at the same time, you can prevent damage. The transthoracic impedance is reduced when you are being defibrillating a patient at the end of expiration. So end of expiration, you should always keep in mind when when the patient is expiring. That means when you're not ventilating a patient, patient's expiration takes place. You do a defibrillation at that point of time. Then the paddle should be very closely attached. You should have a non-salt jelly, a salt jelly without any other drugs in it. That gives a very good shock to this patient. So this is what is in short, which I would like to tell you. But of course, I have some slides which would like to show you in my at the end of this at the end of the talk. Over to you, Tapesh. Thank you so much. If Dr. Rakesh would like to add something to it, I would ask Rakesh and Dr. or Chairperson Dr. Rao also to add if he wants.
Sir, may I request to do that at the end? I'll finish my presentation in 20 minutes.
Sure,
huh?
Sure.
So we can have all the discussion and everybody can give his comments and words of wisdom, sir. So I'll just go through my comments. Thank you for your words of wisdom, sir. That is very nice, sir. So, friends, we move on now after hearing from Dr. Moied, sir. So, this is the term pulseless electrical activity. Now, what is pulseless electrical activity? Earlier, we had something known as EMD. I'm sure many of you must have heard this. This terminology has gone into the waste paper basket now. So, what was electromechanical dissociation? It was actually what is now called pulseless electrical activity. It was seen that when the patient goes into cardiac arrest, there is no pulse, right? And there is some organized rhythm going on. So this organized rhythm with a pulseless state is called pulseless electrical activity. And the rate can be anything up to 100, and they can be normal or wide QRS. And I've shown you two strips of pulseless electrical activity in the monitor. And when the term EMD was used, it was thought that there was pulselessness and the heart was not contracting, but there was electrical activity. So that is why it was called electromechanical dissociation. But it has been seen that though there is no pulse, there is a rhythm and there is some activity in the myocardium. That is why EMD is out and it's now PEA. And PEA is further classified into two types. There's a primary and there is a secondary. So if you have something like a large pulmonary embolism, right? So the entire circulation is shut off. That's a form of primary PEA. And other types of cardiac arrest which lead to PEA, there's so many causes I'll show you. Those are called secondary PEA. And PEA is not a good rhythm to have. The outcome is not good. So guys, I have seen that, the cardiac arrest scenario is a state of acute confusional state. There's a lot of panic and disorganization which leads to a bad outcome. So it has to be well organized and run smoothly. It's an operation we are doing, right? It's like commando operation. I mean, we are not trying to shoot down anybody, we are trying to save. But if you understand what I mean, it's like a commando operation. It should be done efficiently, smoothly, and there should be a team leader. It is very important to have a team leader. I've seen in many places, everybody is doing his own thing and there's nobody directing. And a team leader is very essential, and he should just direct the CPR and should not be actually doing anything with his own hands. And I'm sure in most of the hospitals now, there's a code blue team, people who are ACLS trained, and the code blue team in our hospital used to consist of an intensivist, an anesthetist, and a cardiologist. So this kind of organization is very important for a successful CPR. Now, we have done everything, right? We have talked about cardiac compression, we have talked about breathing, about intubation, and we have talked about defibrillation. So, supposing you start getting a rhythm, you have to know why the patient has gone into cardiac arrest. There should be a cause, right? And unless you reverse this cause, you're not going to be successful. Again, he will degenerate. So these are the 6 H and 6 T's of reversible causes. There are situations where the patient is in multi-organ failure and he's going to go into a cardiac arrest and he's not going to survive. You know that. So these are not the patients who are actually patients whom we are trying to salvage. But this reversible cause table the 6H and 6T should be with you, and you should check them out. This should be checked out whether he has any of these. And amongst these, your coronary thrombosis is very important. And so much so that if there is ROSC attained, the patient should be taken to the cath lab immediately and angiography done. If there is a suspicion of MI, and this is when the patient is somewhat elderly and having the risk factors. And it has been seen a lot of patients have MI in these situations. And then again, intracranial tension is actually referring to the brain. Catastrophic events in the brain can lead to cardiac arrest. Even status or a couple of seizures can throw you into cardiac arrest. The seizure activity runs through your center and leads to cardiac arrest. Then potassium, we know potassium, especially hypokalemia and hypothermia. Hypothermia is one condition. India is a warm country, so it's not really a problem here, but definitely we get sometimes like mixed edema coma patient, or there are poor people, homeless in the winter months when the temperature dips to 4 degrees, 3 degrees. We have had patients. Now the hypothermia patient is not dead till he's warm. Please remember that. No matter what is going on, you have to warm the patient to 36 degrees before declaring him dead, and you have to persist with your CPR. So hypothermia is not dead till he is warm. Then, of course, acidosis does not occur immediately, and hypoxia definitely leads to bradyarrhythmia. Hypoxia is one thing which is always occurring in the ICU, sudden hypoxia, sudden bradycardia. And hypovolemia is not so sudden. Then again, tension pneumothorax. Tension pneumothorax does happen, especially on the ventilator, and we should be aware of this. And then you can have tamponade. Tamponade is often missed. And amongst toxins, drugs like beta blocker poisoning, calcium channel blocker poisoning, and other toxins can always lead to your sudden cardiac arrest. So recent guidelines have pushed forward the use of POCUS, that is your ultrasonography, in the setting of cardiac arrest. Now, what is the role of ultrasonography in the setting of cardiac arrest? So, my dear friends, you cannot interrupt cardiac massage to do your sonography. That should be very clear. And the pauses that we have at the end of 2 minutes of cardiac massage to do the rhythm check is not generally sufficient. And the view recommended is subxiphoid, and this actually should be done after there is ROSC, and that is to determine actually the cause of your cardiac arrest. As you can see, some of these can be picked up like tamponade, tension pneumothorax, or if you're having a patient who had a normal heart, he's got a lot of wall motion abnormalities. So you can kind of diagnose the cause once you have ROSC. But doing it during that is very difficult, and it's actually not possible. But definitely it is now there in the recommendations that you should use ultrasound to help you diagnose. But then again, having said that, you cannot use ultrasound to stop CPR. You cannot use ultrasound to stop CPR. So that should be very clear. Those are also there in the guidelines. Now coming to the drugs that we have, atropine. So the role of atropine is what? Atropine is used for bradyarrhythmias. It is not to be used for pulseless electrical activity or asystole. Do not give it for pulseless electrical activity or asystole. It is to be used in your bradycardia. The heart rate drops less than 40, he can go into hypertension, loss of consciousness, sinus bradycardia. Atropine is wonderful there, and atropine works well for type 2 heart block, second degree type 1 heart block. It does not work for Moied's type 2 and complete heart block. So if you're having Moied's type 2 or complete heart block, you have to go for pacing. So that is the role of atropine, and the dose of atropine is actually 1 mg, and it can be repeated 3 times to a maximum dose of 3 mg. And the duration can be 2 to 3 minutes, and the dose maximum is 3 mg. Then we come to epinephrine. So epinephrine we know is very important, but epinephrine remains a controversial drug in terms of its impact on the outcome. Whatever data we have is controversial and equivocal in terms of epinephrine's effect on the outcome. And when do we use epinephrine? So epinephrine is a go-to drug in PEA and asystole rhythm. So as soon as you diagnose PEA or asystole, you have started your cardiac massage, give epinephrine 1 mg. And in VTVF, you are supposed to give epinephrine after 3 shocks, 3 cycles of shocks and CPR, cardiac massage. And there is no upper limit for epinephrine. 1 mg can be repeated every 3 minutes. And epinephrine, other than that, does not have much of a role. And I will tell you about the physiological actions of epinephrine. Now we come to soda bicarbonate. So these patients who are hypoxic and often suffering from previous metabolic disorders are acidotic. So the SPC does not work here. SPC does not work here because when you give SPC, you are generating more carbon dioxide. The bicarbonate will react with the hydrogen that is there in the acidosis to give you water plus carbon dioxide. And the carbon dioxide has to be breathed out. But because there is circulation impairment, carbon dioxide will not be blown out. So the intracellular acidosis increases, right? The intracellular acidosis increases is something like the situation we have in ARDS when there is falling pH with hypercapnia, right? We give SBC to some extent, but we all know that it's not really helpful. So the situation is the same. For SBC to act in acidosis, here in CPR, the carbon dioxide has to go up. But there are certain situations where you can use SBC. One, you can use SBC in tricyclic antidepressant poisoning. Second, in phenobarbital poisoning. These are 2 conditions where it is very clearly recommended because it acts as somewhat of an antidote. Third, if there was pre-existing severe acidosis, you can use SBC. And fourth, if the CPR is going on for a long time. The dose of SBC is 2 ampules, that is 100 ml, which contains 88 millicurrents of bicarbonate. 50 ml of soda bicarbonate ampule contains 44 millicurrents of bicarb. So you can repeat it again after 15 minutes at the dose of 1 ampule in severe acidotic conditions, though the use remains controversial. Now, intratracheal injections. So intratracheal injections are not recommended. What we need is the IV access or intraosseous access. But if you don't have any of these, because intraosseous is not really developed in our country, I have never used intraosseous. Intratracheal injection can be given. The problem with intratracheal is that you cannot give all the drugs. The drugs you can give is atropine, adrenaline, and vasopressin. Vasopressin can be given through your intratracheal route. And the dose is 2 to 2.5 times diluted in 10 ml. So why intratracheal is not good is because when you're pushing it through the trachea, it has to go into the bloodstream, right? But the circulation is not there. So what amount is getting absorbed, we really don't know. So it's just, you try it, you can give it, but it's in exceptional circumstances. Please do not give intracardiac injections. That's totally out because they cause laceration of the coronary vessels, damage to the coronary vessels. Kindly stop the music, please. So IV calcium. Now, what is the role of IV calcium? We used to give IV calcium a few years ago. And that was because certain preliminary data showed that IV calcium helps. But IV calcium has been found to be detrimental because in the low perfusion state, when you give IV calcium, the serum calcium actually becomes quite high. And calcium, if you raise the serum calcium, it actually goes into the cells and helps in causing cell death. So calcium is not recommended. In certain circumstances, yes. If there is pre-existing hypocalcemia, one, if there is hypermagnesiemic death, if there is hypermagnesiemic cardiac arrest, IV calcium counters hypermagnesemia. So these are 2 conditions where IV calcium can help you. Now, I told you I will tell you about the physiological actions of ADR. So these are the physiological actions of ADR. It acts on the alpha receptors on the coronaries and cerebral vessels to improve the perfusion, increases the heart rate in Brady and PEA, and it also, converts fine VF into coarse VF. So this is the chance of successful cardioversion of VTVF. So that is something which is very interesting, and of course it increases myocardial contractility. But like I said earlier, it has not been shown convincingly to improve outcomes. So there is no real point in pumping in too much ADR also if there is a prolonged CPR, though there is no upper limit to ADR. And the flip side of the coin is that, when you have a cardiac arrest, often the catecholamine levels are high and you're pushing in ADR that can lead to toxicity also. Now, this is just to show you the algorithm. I'm sorry, the typing, etc. is a little small, but this is the algorithm for VTVF. First, you do 2 minutes of CPR, then shock, check the rhythm, then this goes on for 3 cycles. At the end of 3 cycles of shock and CPR, that is your cardiac massage, you are normally successful in 75% of VTVF to break the rhythm. And if at the end of this, you are not successful, then you push in adrenaline and you give 300 milligram of amidron bolus. So you may wonder why you are giving bolus amidron. And amidron causes hypotension, and so brady and all, we always give it over 15 minutes, 150 mg loading. So the answer is the patient is already gone. There's nothing there, and you want immediate results. That's why it is given as 300 milligram fast. That's amidron, and further on there are pathways algorithms which go into cardiology. So if you have any questions, we can discuss them at the end. I will not go into that. This here is the asystole PEA pathway, and as you can see right at the top is epinephrine. It has to be given early, and it's supposed to help here. And this is a new recommendation in the AHA 2020 guidelines. And after that, you have to do your CPR, check the rhythm, and continue to do so. But asystole and PEA are bad rhythms. The outcomes are not good, especially asystole. Now, indications of spontaneous circulation or ROSCE. So one is your return of pulse and blood pressure, and very important is PET CO2. So I think most of us are not familiar with this because we do not have this, but definitely many of us do use PET CO2. So PET CO2, if it rises abruptly, right, that's more than 25. So this is a controversial number, but if it jumps a little, around 25, then that means your circulation is improving, or if it goes beyond 40. Okay, these are not sacrosanct numbers, but if it starts rising, that means your circulation is improving, right? And that means your CPR is being effective and you have achieved ROSCE. And then, of course, if there is an invasive arterial line and it starts showing a trace, that means your blood pressure has improved. So what is the concept here with EtCO2? So if you see on the right, there is an alveolus and there is a capillary, and blood is flowing across the capillary and CO2 is going into the alveolus, which goes through the ET tube and is sensed by your EtCO2. So normally, your venous PCO2 is around 45 and 40 is your arterial, and there's a difference of 2.5 to 5 between your EtCO2 and your arterial PCO2. So now if there is no circulation, which is happening in a cardiac arrest state, blood will not flow across the capillaries and CO2 will not diffuse into the alveolus, and you will get a very low CO2 in your PET-CO2. So if the circulation improves, the CO2 will wash out into the alveoli and will start rising. So that is the rationale behind a rise in PeT-CO2 signaling that you are achieving ROSCE. So I hope I was able to clarify the concept behind the rise in PeT-CO2. And the numbers are approximate here. There are guidelines, like I told you, there's a European guideline, there's an American guideline. They tend to differ somewhat in their recommendations as far as the numbers are concerned. So this is just to show you the arterial trace. And if you are getting something like this, that means definitely you are achieving ROSCE. Now coming to the physiology in cardiopulmonary resuscitation, to which Moied sir had alluded a little, and I will just try to explain this because this is important to understand as to what is that we are trying to do when we are doing CPR. So, my friends, we are pumping the heart, right? And we are ventilating the lung. So we are trying to achieve perfusion, and the brain is the most, let's say, the sacred organ here and the most susceptible organ to hypoxia. So the idea is to maintain circulation to the brain and coronary perfusion. So when you are doing your cardiac compression of the heart is like systole. Recoil is diastole. So that is very simple to understand. And the recoil is very important. That is why your cardiac massage should be very good. Because the recoil creates a vacuum-like situation in the thorax and it sucks in the blood into the heart. So blood returns to RV from IVC and the brain in recoil. And rescue breath is like a PPV because you're giving a positive pressure breath. So again, I repeat, do not give rescue breaths more than 6 to 10 per minute and not a large volume. The chest should just rise. This is very, very important. Otherwise, if you give large minute ventilation, you are going to impair the return of the blood and your patient is not going to make it. So please remember this because we make this mistake. I've seen this many times. So rescue breath is like PPV and it decreases the return from the IVC and the brain, and it actually impacts the cerebral perfusion pressure. So the cerebral perfusion pressure is the one which is perfusing the brain, and we all know MAP minus ICT is the cerebral perfusion pressure. So in this situation where you are giving a positive pressure breath, your return, the venous return from the brain also decreases, and because the venous return decreases, the blood volume increases in the brain, and thereby the MAP minus the ICT actually decreases. So this is a very important concept to understand because we'll just show you some slides about rescue devices. And the coronary flow, which is again very important because the heart is not getting this blood, then you're finished. The brain cannot do anything if the heart is not pumping, right? So the coronary flow is diastolic blood pressure minus RA pressure. The coronary flow depends on the diastolic blood pressure minus the RA pressure. And the RA pressure is somewhat higher than the LA pressure in cardiac massage because the anatomy of the heart is like that. When you give the cardiac massage, there's more pressure on the RA than on the LA. So I hope I was able to kind of clarify the physiology. The most important thing to understand is that the compression of the heart is like systole, recoil is like diastole, and filling of the heart occurs in recoil. That is why recoil is very important. It creates a vacuum-like situation in the heart. It sucks in blood from the IVC and the brain, and return from the brain is very important. Otherwise, if there's more blood in the brain, then the ICT rises and the perfusion of the brain decreases. And again, rescue breath, don't give too much positive pressure ventilation and don't give too much minute ventilation. And coronary flow is, diastolic blood pressure minus your RA, depends on how good your cardiac massage is. Now, friends, we have all heard about the Cpr devices, right? But we have not used it. I never used it, and I don't think anybody here has used it, except, of course, our esteemed panelists who are the experts in Cpr. So on the right is the rescue pump, and on the left is ITD, which is impedance thoracic device. So at the beginning, let me tell you, these are not recommended. The AHA and the European guidelines do not recommend the devices. But there are situations where they can be used, and it is important to understand how they work. And I don't think a session on CPR would be complete unless we understand these devices. So as you can see, the rescue pump, it's placed on the chest, and the rescuer is pushing it down, and it's got a vacuum-like shape at the base, which exerts a greater negative recoil than is exerted with your manual compressions. And it's got numbers on it, and it tells you how much force to actually put. So it's quite a sophisticated device. And on the right is your impedance thoracic device. Now the impedance thoracic device is attached to your airway. It has a port for the patient and for the ventilation. And this actually helps in creating a negative pressure in the thorax rather than a positive pressure when there is return of blood occurring in the blood. And I'll just show you this. So what happens. So here you see on top is the compression, right? Compression is going on. ACD is the rescue pump. It is called active compression and decompression. IDD is your impedance thoracic device, and CPR. So what is happening here is you are pressing down with your rescue pump, and to your airways, your ITD is attached, and you compress down, air is pushed out, fair enough. Now, the fun actually is in the recoil. In the recoil, what is happening is that this ITD device, which is attached to the airways, it actually blocks the inflow of air during the period of recoil. Because if the air comes in during the period of recoil, then there will be a positive pressure created during the period of recoil. And in recoil, you are getting your blood back into the heart from the IVC and down from your brain. So the device works like this, that it prevents a positive pressure occurring during the period of elastic recoil occurring during your compression, and thereby improving the flow to the heart from the IVC and from the brain. And as you can see, it has been typed also. It decreases the airway pressure during the period of relaxation or recoil. Thereby, the preload is increased and increases cardiac output, ICP is lowered, and cerebral perfusion is increased. So this is how this device works. There are certain modifications, and different companies, etc. But this is the essence of the devices that we have. Now, how did this device actually start? It is very interesting. There was out of hospital cardiac arrest, and a person, the rescuer, used a toilet plunger. He placed it on the heart and gave compressions, and the patient survived. And then this was looked into, and they realized that the recoil, which is much stronger because of the vacuum-like effect. And a lot of work was done by different people, amongst them being Dr. Keith Lurie, and they have actually even combined this with a head-up position during CPR. So the head-up position works because there is a gravity-dependent drainage of venous blood back into the heart. So if the blood is returned from the heart into the from the brain into the heart, obviously your cerebral perfusion pressure will increase, because if you have more blood staying back in the brain, then your CPP will decrease. So what is the evidence? So the evidence is meta-analysis. This is a paper from 1999, and after that there have been Cochrane analysis, and we have the AHA and the European guidelines of 2020-2021, and they do not recommend because there is no significant benefit. So that is the final take on this. But yes, in certain situations where you cannot perform CPR, especially in ambulances or in planes, or because of certain infection control practices, it has been recommended that you can go ahead with these devices. So that is the word on these devices. Now, there are certain situations where we wonder whether we should do a CPR or not. So your CPR is actually done in witnessed cardiac arrest. Now, if you have an unwitnessed cardiac arrest, you do not know the duration of cardiac arrest, right? And here one has to take the call whether one should do a CPR or not. So if the time elapsed is more than around 10 minutes and you're getting a flat line and the pupils are not reactive, I don't think we should do a CPR. This is an individual decision, because if you start doing a CPR and you get something, but the patient is already brain dead, you subject the patient to financial stress, emotional stress, and these kind of situations are very ugly to deal with. So if the patient is, brought into the casualty without a witness arrest, and you assess him and you think that you should not be doing a CPR, you are justified, but then you have to take the call. And sometimes this happens in the ward also. Sister walks into the ward, into the room, and finds the patient pulseless, and then one has to take the call. But generally, if in doubt, do the CPR. So the final word is, if in doubt, do the CPR. Because, after all, we are doctors, we have to save lives, and there are medico-legal issues also. Now, that was when not to do the CPR. When to stop CPR? So when to stop CPR is one, if the rhythm, initial rhythm is asystole, and you have done it for 10 minutes, there is no ROSC. Then more than 30 minutes of CPR, no ROSC, whatever the rhythm. ET PCO2 less than 10 for 20 minutes. So again, ET PCO2 numbers are a little controversial, and you should not just look at the ET PCO2 and say it's less than 10, so I'm stopping the CPR. It has to be taken in conjunction with everything. Then there is a situation known as electrical storm, where there is recurrent Vt. So friends, this is not an uncommon situation, especially those of you who work in CCUs, cardiac intensive care. If the patient after 3 VTs, you give an amidron, if he's got torsad, you have given magnesium, you've given lidocaine, I think there comes a time when we have to take a call. And if the EF is good, fair enough. But often these patients have a poor EF, 20-25%. These patients, I think we have to take a call and stop the CPR. So stopping the CPR is a thing that has to be taken with a little bit of wisdom, and we have to stop the CPR at times in certain situations when it has gone on for too long. Having said that, it is important to realize that prolonged CPRs overall have better outcomes. Prolonged CPRs have better outcomes, so it depends on how the CPR is going, what is your rhythm, how is the patient. So give the maximum chance to the patient. And especially hypothermia, prolonged CPR, which I told you, a hypothermic patient is not dead till he's warm. And second, if you have diagnosed pulmonary embolism or acute myocardial infarction as the cause of your cardiac arrest, you give the thrombolysis and the CPR has to go on for 60 minutes here. So that is because the thrombolysis takes a while and circulation will take a while to get established. So this is something you should be well aware of. And this is not an uncommon situation, pulmonary embolism and MI leading to cardiac arrest. And if you are diagnosing MI and you get ROSC, you should be taken to the cath lab. Now, coming to the complications of your CPR, you are well aware, we break the ribs, unfortunately. The patients are osteoporotic, especially the elderly, and you can practically damage anything in the thorax. You can practically damage anything in the thorax and even upper abdomen, laceration of the stomach, etc., etc. There can be pneumothorax, there can be cardiac tamponade, pulmonary artery laceration, there can be pulmonary hemorrhage, pulmonary edema is very common. So all these complications can occur. So your mind should be open to these complications, and if the patient is improving, starts deteriorating, then you should think and try to pick up these complications. Because after initial improvement, if the patient deteriorates and you don't think of these complications, you are not going to lose the patient. So please be cognizant of these complications, and they occur frequently enough. So that was about the complications. Now we come to certain special situations. CPR in pregnancy, and here we are talking about term pregnancy when there's a gravid uterus which is quite full. So what do we do? A pregnant lady, 32 weeks, 36 weeks with a full baby in the tummy gets a cardiac arrest in the ICU. So we have to here act judiciously. We have to talk to the gynecologist and the neonatologist. The team has to be involved, but you are the intensivist. So here, the mother is the priority. Please remember, mother is the priority. And the difference in CPR is because of the gravid uterus, the heart is pushed up. So a hand position will go up for doing the cardiac massage. One. Secondly, the gravid uterus compresses the vena cava. So the patient has to be somewhat in a left lateral position. Has to be somewhat in a left lateral position with the pillow below her hips. But the shoulders have to be on the bed, otherwise you won't get the cardiac compression. So the slight alteration in the hand position and the patient's position, and try and do a manual uterine displacement to the left. You have to call the gynecologist, I think, for that. The gynecologist has to be involved there. Should be called immediately. And if within 5 minutes you are not able to achieve ROSC, emergency LSCS should be done. So this is very, this happens. There are pregnant ladies who are term and they get cardiac arrest. This is not, I faced this situation a few times, and this is, if you want to save the patient, you have to perform emergency LSCS, and the time duration is also marked out at around 5 minutes, but it has to be done in conjunction with the neonatologist and the obstetrician, most importantly. And prior to that, cardioversion, any drugs that you want to give is okay for the fetus. So the idea of doing the emergency LSCS is that when you deliver the baby, whatever happens to the baby, of course, you try to save the baby also. So when you deliver the baby, the stress on the circulation of the mother decreases. The compression of the aorta and the IVC most importantly decreases, and the overall stress, the metabolic stress on the mother decreases, thereby improving the outcomes. So that is CPR in pregnancy. Then there are situations as patients' longevity increases, patients are getting more and more cardiac devices. And this is an example of a cardiac device. ICD is implanted, and generally it's in the left side, and this is the position, it's the subcutaneous area. So you should be aware of this. And if you're defibrillating, do not place the paddle over it. Otherwise, the device gets destroyed. So you have to keep it a few centimeters away from the device, the paddle, when you're defibrillating. And sometimes, the device starts firing and it interferes with the rhythm, with your CPR. So to silence the device, you can place a magnet over it. So this is about cardiac devices, and this is actually more in the coronary care units, but we in general medical care units also come across these patients. So you should be aware of this. Then ECMO CPR. What is the status of ECMO CPR? So ECMO CPR, again, like out of hospital cardiac arrest, is a thing of the West. Currently, we are not so advanced in doing ECMO CPR. In fact, we have to gain first, make rapid strides in doing ECMO in patients who are, having ARDS and other conditions. VV ECMO itself is not well established in a country. And before doing ECMO CPR, we have to actually establish VV ECMO in conditions of ARDS and other situations. So I don't think I'm going to go into too many details, but yes, SLO registry recommends it, and there is improved outcome, but you have to do it in dedicated ECMO centers, and the patient correction has to be appropriate. That is most important. So I will not delve into too many details because I don't really know how many ECMO CPRs we are doing in a country, and I think it's going to take a long time before we are going to do ECMO CPRs. And it's a VA ECMO CPR that we do in these patients. Then COVID, of course, so I really don't need to say anything here, but adequate precautions should be taken. Do not get infected and avoid aerosolization in CPR during COVID for COVID patients. Then there is a term called Cardiopulmonary Cerebral Resuscitation, CPCR. Some of you may have heard this. So what is Cardiopulmonary Cerebral Resuscitation? Is there something else we do for the brain? So it is nothing unusual. It is just your CPR, but the idea is your resuscitation is not just cardiopulmonary. You are trying to save the brain also, right? Because the organ which spoils your party as far as the CPR is concerned is your brain, because it is most susceptible to hypoxia. We all know that. So the idea behind putting this is that the focus should also be on the brain, and then in your post-cardiac situation, therapeutic hypothermia has to be done. So that is why this term has been coined. Otherwise, everything else is the same. Now, this is to show you an adult tachycardia with pulse algorithm, right? There is a pulse here. So this is not really a cardiac arrest situation, but if this patient with an adult tachyarrhythmia, whatever the adult tachyarrhythmia is, if he gets hypotension or loses consciousness, then what is to be done? So this patient has to be given synchronized cardioversion. So you can see the indications here, and here you have to synchronize, because in this patient there is a pulse, and if you do not synchronize, you will convert this into VTVF, which is pulseless. It will degenerate. So it's very important to synchronize here, and then as far as the classification of adult tachyarrhythmias is concerned, you have to see whether it's narrow QRS or wide QRS. So narrow QRS is supraventricular and wide QRS is generally 85% of the times VT. So if you have a VT with a pulse, either you can defibrillate or you can use amiodarone. It depends on you. And generally, the drugs which are used for tachyarrhythmias, for your supraventricular arrhythmias, if you are sure it's PSVT, that is monomorphic and regular narrow QRS, you can try adenosine. Otherwise, for all adult, tachyarrhythmias with pulse, amiodarone is good enough. So that is one drug that you can give in all adult tachyarrhythmias. Then we come to the Bradycardia algorithm. So the Bradycardia algorithm, bradycardia is what? It can be sinus bradycardia going below 40, or it can be AV block, first degree, second degree, or a complete heart block, or it can be some other kind of a bradycardia, but not pulseless electrical activity or asystole. That is a separate pathway which I had showed you earlier, the treatment for that. So here again, if the patient is destabilizing in the sense he's getting hypotension, but there is a pulse, or if he's getting pulmonary edema, losing consciousness, you have to take the appropriate action in terms of giving atropine. So atropine works for sinus bradycardia and it works for second degree AV block type 1 only. So type 2, that is Moied's type 2 and complete heart block, your atropine does not work, you have to do pacing. So if you have given atropine for sinus bradycardia, 1 mg, you can repeat it again after 2-3 minutes, and you can repeat it 3 times. 3 mg is the maximum dose. And if it's not working, you can start a dopamine infusion or epinephrine infusion. If the patient continues to be in bradycardia, then you should go in for pacing, transcutaneous, but transcutaneous is not really that effective. You generally have to go in for intravenous pacing. And the situation where you get this bradycardia, the complete heart block kind of a situation, is very, very common with CRF patients and hyperkalemia. The commonest setting for this is patient coming to your ICU with complete heart block or a high-grade block, and the CRF and potassium is 6.57. So here you have to do pacing and you got to dialyze, and these patients recover very well. This is a very common scenario. Now coming to this, something which looks very trivial, but I think which is the most important thing is prognostication and communication. So when the patient goes into cardiac arrest, either sudden or not really expected, please talk to the family and handle the situation, maintain decorum at the bedside, and there should be no untoward incidents happening, and the thing should be handled well. Communication is the key here, and you should be aware of DNR status of the patients. At times, the duty doctors do not know which patients are DNR. So that becomes a very embarrassing situation. The family has given DNR and he goes into cardiac arrest and you do a CPR and you revive him. So these kind of situations should be avoided. And this is a death situation, and these are serious situations. So they have to be handled carefully with good communication skills. Now coming to the prognosis of your CPR. So this is a recent study published in Intensive Care Medicine 2020, where in a general ICU, they showed that 1 in 6 patients with ICU cardiac arrest and resuscitation was alive with good functional status at 6 months. So this is one study, but the numbers vary, right? The numbers vary, and the outcome actually depends on what rhythm you have. Like I told you, VT-VF has a much better prognosis than your pulseless electrical activity, and asystole has a very bad prognosis. So overall outcomes in hospital cardiac arrest, 10 to 15% return to active life. So that's not bad at all, but this is high quality CPR. This is high quality CPR. So if you look at the number, if you have 100 arrests in your ICU or in the ward and you are attending as a code blue, if you do this well, you'll be saving 10 to 15% of the patients. That is not bad at all. So CPR has to be learned as a skill. The concepts have to be understood, and most importantly, it has to be organized well. There's a lot of confusion that has to be avoided, which is occurring when CPR is going on. So coming to the last few slides, so some question answers for you. Can cardioversion be done in the prone patient? So the answer is yes. Like I told you, you can do a biaxillary cardioversion. In each axilla, you place the paddle. But after that, you have to, for all other kind of CPR, you have to make the patient supine. Then where has vasopressin disappeared and why has it disappeared from our resuscitation list? So vasopressin came up, but after that, it was found that it was not as effective as ADR, and vasopressin had come up for two reasons. One, it was very long acting, so a single shot was good enough. Second, it was much better with acidosis. But whatever trials were done did not find it to be as effective as ADR. But having said that, if ADR is not there, you can use vasopressin. But then again, vasopressin is a very powerful vasoconstrictor, and if there's coronary ischemia, it can be slightly dangerous. Then any role for higher doses of ADR? So again, I think I told you there's no role for high doses of ADR. Then if you have achieved ROSCE, when should massage be stopped? So this is a transition period and should not stop massage immediately. Continue massage for 2 more minutes. That is the recommendation. Then ABG or a BPG should be sent as soon as possible because it tells you the etiology at times. It tells you the blood sugar, it tells you the electrolytes, it tells you the pH. So this is very important. Do a ABG or a BPG as soon as possible. Then can we give a precordial thumb? Can we give a precordial thumb? So yes, we can give a precordial thumb if there's nothing else. If there is nothing else, there's no equipment, nothing, you are there alone, and thumb can work sometimes for VTVF. You bring the fist down on the chest from around 10 inches and just give a thumb. Sometimes it can work, but this is the last resort if there is no devices and you have nothing to work with. Then at what blood pressure do you not feel any any pulse? That is your carotid pulse. So the carotid pulse is not felt if the blood pressure drops systolic below 60 and femoral disappears at around 70 and below 80 your radial is not felt, approximate numbers. So this does atropine work in complete heart block? No. Is there any contraindication to cardioversion? Is there any contraindication to cardioversion? So here the tangible answer is there is one, that is digitalis intoxicity. If the patient is suffering from digitalis toxicity, do not cardiovert unless the patient has pulseless VTVF. No, digitalis toxicity can have all kinds of arrhythmias, tachyarrhythmias, and including pulseless VTVF. And pulseless VTVF you have to cardiovert, but the other kind of arrhythmias, tachyarrhythmias, can actually worsen with cardioversion in digitalis toxicity. The treatment is the antibodies here. So the next question is, can there be a confusion between asystole and VF? Can there be a confusion between asystole and VF? Yes. So this is again very important because the treatment protocol for asystole is totally different from VF. And the VF here is a fine VF, a very fine undulating line, and you are not sure whether it's VF or asystole. So you have to be very careful. If you're not sure, do not cardiovert. Do not cardiovert. Continue cardiac massage till it becomes clear. Now, is there evidence for benefit of drugs? Yes, atropine works in some bradycardias, but adrenaline is controversial, and the other drugs I have told you. Then what is the mechanism for asystole finally in these situations? So for both tachyarrhythmias and brady and asystole and pulseless electrical activity, there are multiple pathways and mechanisms which work, including coronary ischemia and including your myocardial injury, your disturbance of your metabolic milieu, and the autonomic disturbances. There is no unifying mechanism which has been worked out. All these together, either one of them or all four of them, work together to finally bring the heart to asystole. So that is about the mechanism. Then what is the cause of sudden cardiac arrest in healthy adults? Like I'm by God's grace healthy. If I get a cardiac arrest, then what is the cause? So it has been seen in a large study. There were around, I think, 800 patients, and a lot of them survived. So they found that in 40%, despite extensive investigation, they were not able to find any cause for sudden cardiac arrest. So the obvious answer is there was some fibrillation, some tachycardia because of some channelopathies, abnormalities. We know the heart is predisposed to all kind of arrhythmias. You can get them suddenly, and that is what is the commonest cause of sudden cardiac arrest in healthy adults. And finally, the dose of magnesium sulfate in ventricular tachycardia. So do we give magnesium sulfate in ventricular tachycardia? The answer is yes and no. Yes, we give if Vt is torsade, and no, if the Vt is not torsade, we normally do not like to give magnesium sulfate. So if torsade is there, and you should be able to recognize torsade on the monitor, it's like twisting of the points. That's the way it is described, but I think you should see it. I'm sorry, I couldn't put the picture. So the dose for this is very important: 1 to 2 gram in 10 ml over 10 minutes. It's very important. 1 to 2 milligram in 10 ml over 10 minutes. Now, just coming to the last couple of slides. So please, once you have retrieved ROSCE, you have to take care of the patient, and we go into post-resuscitation care bundles and guidelines. And all patients with M5 or below should undergo hypothermia. And these are 2021 European Resuscitation Council guidelines. Please go through them. And these are all, latest guidelines for CPR as well as post-resuscitation care. So all of you should go through this and update yourself. And so finally, what was new in the recommendations? One, intraosseous is not that good. And ADR as soon as possible in non-shockable rhythm, and after the third cycle of shock and cardiac massage in VTVF pulseless. Focus is not used for stopping CPR, but it should be encouraged to diagnose the cause, and the CPR pregnancy algorithm has been modified and proposed. So friends, I hope I was able to help you to understand certain concepts and the process of this life-saving procedure, I think, which is something which all of us should be very well aware of. It is the core of intensive care. It is life. And like I told you, the numbers are not so bad, but progress in CPR has been slow. Progress in the development of CPR has been slow. And the devices also, there have been studies which have shown they are useful, etc., etc. They improve the cardiac output. The devices I told you in a manual CPR, the cardiac output goes up is 15 to 20% of the normal one. But here with the devices, it goes up to 40 to 50%. So, but the recommendations are not there. So finally, thank you very much. And quality cardiac compression is the key. So going back, please remember quality cardiac compression is the key. And second is defibrillation. These two are the main game changers. Have a team leader. There should be no confusion. It should work like a commando operation, and have some kind of a checklist ticked off, and analyze your CPR after the event. What went right? What went wrong? So you can have a quality check. Thank you very much for your patient hearing. And I request Dr. Moied sir to take over the mic and to share his thoughts and our esteemed panelists. Thank you, sir.
It's an excellent talk delivered by Tapesh. It's really, Dr. Tapesh, it was a wonderful talk. Wonderful hearing you as well. Do we have some time? There's no question. If you have some time, then probably I would like to share some slides if possible.
Yes, please.
I'm just sharing. Let me see if I can do it. Where is my... I would like to share the slide, but then I cannot see my desktop.
Sir, pop-up is coming into your screen. Sir, click on the share screen.
Yeah, I know. I can go there, shared screen.
Yeah, I'll guide you, sir, once again. Now, sir, pop-up is coming into your screen. Entire application, Chrome tab. click on the entire screen. Below that screen supposed to be share, select it, and below that share button is there.
So entire screen is there. Okay.
Yeah,
then
entire screen. Yeah, entire screen. Below that screen supposed to be share. Click on that, and below that share button is there.
But, after that, this is what share. So this is what share, na? But let me see.
Sir.
No, this is.
Yeah. Sir, now minimize your Google Chrome and select your presentation.
My Google Chrome should be minimized.
Yeah.
Okay.
Acha, sir, you have opened into this. Yeah. Now, sir, you can. Yeah.
Can you see it?
Yes, sir. Yes, sir. It is visible along with your video. Over to you.
But I cannot see my video, right?
Yeah, you can't see, but we can see your video.
All right, that's something very decent. Anyway, so since I was waiting for my chairman and Dr. Akish.
Sir, Dr. Moied, sir, you have to hide this bar. Click on hide.
Which one? Yeah, this one.
Yeah.
Okay. So what do I hide?
That's all. Carry on.
Okay. So as I said, let me add to what Tapesh has said. Certain thing like okay, I'll just go on with the slide so that in between I can add it. So Indian Resuscitation Council, as I said, is the recent thing which has come out. We published our guidelines in 2017. We had 3 different guidelines to start with, which was COLS, PCLS, and CCLS. And then in 2019, we came up with CCLS for COVD, as COVID patients. And the most important thing is they are all. It's a unique guideline. If you see, the guidelines are unique, and they've been all published in Indian Journal of Anesthesia in 2017 and 2019 as well. The uniqueness is that the guidelines are framed based on the target group. As I said, we are dealing with people of different level of knowledge, literacy, understanding. So naturally, accordingly, we had to frame our guidelines so that everything can be palatable for them. And so we made it very simple for them. We made it color-coded, and each guideline is integrated and standalone so that we can switch over from one guideline to the other as and when needed. And these guidelines are very easily learned. And as I said, it is accessible to all category of people. It's very simple, easy to learn, and it's very cheap to learn as well. And the other thing which we were talking about today, as Dr. Tapesh has always said, that most of the guidelines, what we are talking about, they're all consensus-based and opinion-based. And even if you talk about the CPR is about 1/3 of the normal cardiac output, what Tapesh was saying is 15 to 20% of the cardiac output. Now, that's also an opinion-based. There's no concrete evidence on that. And especially the optimal positioning of the hand and the depth and speed of compression, they are also, they are all, they are opinion-based, consciences-based. There's no evidence, concrete evidence, no robust RCTs on them. And even the 30:12 compression is also on expert opinion and consensus opinion. So there's no, scientific evidence on those things. And very interestingly, if you see the 220 guidelines, the AHA, the American International Guidelines, and they had around 491 recommendations total. And out of that, only 6 recommendations were level 1, level A evidence. That is only, if you say this, it's only 1.2% of these, all over whatever recommendations they have said. The only 6 patients, of these recommendations are, 6 recommendations are evidence-based. And, it indirectly tells you that the challenges which we are facing to really have strong evidence on what we are doing. And as Dr. Tapesh has very rightly said, that after 2010, 2015, if you talk about 2010 to 2020, in 2012, we started incorporating something very new. And then there was a plateau. If you see the survival rate has been plateaued, despite adding the AED, automated external defibrillator. And this is what I was trying to tell you. If you see the optimal position, what we were discussing was the middle of the chest. Now that if you're trying to compress at the middle of the chest, what primarily you're doing is you're compressing the root of the aorta and the left ventricle, and that results in obstruction of your outflow. So primarily what you're talking about, the international guideline, according to that, if you go, probably you would be doing more harm than good. So what Indian Resuscitation Council has recommended is two finger above the xiphisternum, and then you put your heel of one hand, the heel on the top of the heel of the other hand, and then you compress. And that is much more scientific and reasonable as per your evidences through your CT analysis and the TE. You see that primarily where you're compressing is on the left ventricle, not on the root of the aorta. So this is one study which I'm quoting. And there was another study, which very interesting study, where they said that if you are trying to compress at the lower half, that means at the what I was talking about, if you compress there, probably you are trying to raise the peak arterial pressure by 20 millimeter of mercury, and that is more evident based, and we have accepted that and adopted that in our guideline. This I have already discussed, that life band which has come across, because we are talking about most importantly it is something which is going to increase your blood flow, and it is much more specific, and it can be applied at any point of time without compromising your compression, because as we are saying that high quality CPR is the buzz of of any cardiac resuscitation. So naturally we cannot compromise on that, and that has to be very specific and to a very specific depth also. So manual CPR probably would not be able to achieve the target, which can be, of course, if you are experiencing day in day out doing it, practicing it, probably you can do it. Otherwise, this is the concept which they come out, which is the cardiac heart pump. We talk about this heart pump mechanism for the first 15 to 20 minutes, and subsequently when it becomes flaccid, then we talk about the chest pump, and then when we combine these two, then we are trying to compress the whole of the chest, and that load is being distributed both over the chest, the lungs, along with the heart, and then that gets a better compression, which is being done by the life band or the auto CPR. And these are the evidences which you see that the coronary perfusion is much better when we talk about this auto CPR, and the survival is much better when we talk about the conventional CPR. And again, if you see, the return of spontaneous circulation is much higher, significantly higher than manual CPR, and the perfusion blood flow, percentage of perfusion blood flow is blood flow is much more higher when we talk about the even the brain circulation is higher than when we talk about the auto CPR. This is something which is recent. Dr. Tapesh was saying, but I think he has not incorporated in his slide, so I thought I would add it. This is the sixth link, which is there, which they have started because they rationalized it by saying that since we are doing a post-cardiac care arrest care, and which is prolonged, so they have divided this post-cardiac care into a recovery period as well. So they have added this. Rest of the thing is almost the same. Even for out of hospital cardiac arrest, they have done the same thing, and they have added the sixth link, which is there in the recent guidelines. The layperson administered CPR, we have already talked. I'll just done. This is something which I wanted to tell you, because the recent guidelines they have very categorically highlighted this point, that is double sequence defibrillation. And this was there in the previous guideline. This has been this has been discussed in this guideline as well, and they have categorically mentioned there are a lot of studies which have been done, and they said that it is not going to cause any much better, and it is straight away it is not recommended. So what is double sequence defibrillation is when we add 2 AED and we give 2 shocks. We give shocks with this and this AED simultaneously at the same time, and that is what is double sequence defibrillation, and it is primarily not doing any good, and that is why it is not being recommended in this 2020 guidelines, and they have very categorically mentioned on this. this is what again. If you see, I've already said in my first discussion that when even after adding in your AD, because we are talking about AED because we are talking about ambulance services in our country where AED is not very AED is not it is not available in most of the areas nowadays. Thanks to our government, now we are having in public places we are having AED in most of the places, but this is not available in most of the places, and it is not there since ambulance services is not there. We are not having AED in most areas, and when we are trying to convince people that AED is it improves your cardiac survival. But if you see that even in European countries, or when they have framed this guideline, less than 40% of the adults they receive they started the layperson initiated CPR, and out of them less than 12% of them have started AED before the EMS have arrived. That means even if you have AED, it is not compulsory, it's not mandatory probably that you will be able to apply your AED. So this is something which is very eye-opening for all of us, that we really, even if we have AED, probably we are not applying AED before the EMS teams comes to us. This is something which I thought I would like to tell you, which is recent in this 2020 guidelines. Initially, we had pediatric rescue breathing was 3 to 5 seconds per breath. I mean, after each 3 to 5 seconds, we used to have a breath. But now that recommendation has been changed, and it is 2 to 3 seconds. After every 2 to 3 seconds, they are asking for a rescue breath. And naturally, that is with a lot of evidences they have come across, and they said that this is better. And overall, if you see, they are saying that it is for pediatric patient less than 4 years to 8 years, we can go for 2 to 3, 30 breaths per minute. And if it is more than 8, you can go for 25 breaths per minute. So this is what they are saying. And the other thing is, they have recommended every 5 minutes, within 5 minutes, you need to go for giving epinephrine after beginning your CPR. Now, this is the new recommendation for pediatric patients, that after you start your CPR, you should give your ADR if it is possible, if it is available within 5 minutes. I'll come to that later on. Now, these are the recommendations. There are a lot of recommendations which are there in the national guidelines. That as a 6th link is there. Emphasis on early administration of epinephrine is already there. And if you see that early epinephrine administration within 5 minutes of cardiac arrest and repeat doses every 4 minutes to coincide with alternate pulse check is something which they have prescribed and recommended. And separate algorithm for return of spontaneous circulation they have added. Now, this is very important. Neurological imaging, MRI, CT scan, and EEG, they have recommended in post-resuscitation care to see ultimately what Dr. Tapesh was saying was that CPBR, this term, CPCR or CPBR, was the initial term which they came across with, that cardiopulmonary brain resuscitation or cardiopulmonary cerebral resuscitation was the initial term which was used instead of CPR. And because at the back of our mind, the main target was to resuscitate the brain. So if you are, and since it's an indirect resuscitation, primarily we are not doing any active work on the brain. So that is why the terminology was shifted to cardiopulmonary resuscitation, because whatever activities we are doing on the heart and the brain. So and heart and the lungs. So that is why the terminology from initial CPBR or CPCR has been converted to CPR. But that term CPCR was very apt because at the back of our mind, what the target was to resuscitate the brain, because otherwise we'll have a vegetative person. So naturally that was the primary target, and that is why in the recent guideline they've added the neurological imaging and EEG and as a very important component in post-resuscitation care. So we need to keep this in mind. And this is one breath, as I said, I've already discussed. Less than 1 year child, it is 30 breaths per minute, and more than 1 year, it is more than 25 breaths per minute. It is advised to have an ETT cuff tube in pediatric age group, and new algorithm for pediatric tachycardia is there. Umbilical vein catheterization is again there. Two thumb circle as encircling compression is which is there, which was existing. Now this is something which is added. The facial drop, arm drift, and speech difficulties has been changed to fast. That is time to call emergency number for stroke. This is for stroke patients, but anyway, this is nothing to do with us. Something which I would like to add is use of waveform capnography. Now, this they have recommended that it should be a continuous process while you're doing a CPR. That means we have to. It is better that if we have with you always to have a waveform capnography while you're resuscitating a patient. It gives you a better outcome, and use of mobile technology reasonably helps in ACLS, because what they are now trying to do is you should always have a visual feedback, and you should have an alert system within your mobile system. Since because of the mobile, we can have this advantage of alerting people. That means if the patient sustains cardiac arrest, if it is outside hospital, then a person who's trained in CPR, they can be given an alert call, and they can come before the in between where the layperson is trying to do a CPR. So they can be immediately called. So that is an alert system, and whatever you're doing, that feedback should be on a visual platform. You can have an audiovisual feedback so as to have improve your whatever you're talking, techniques you're doing. The other thing is now, as it has been said, amiodarone and lidocaine. Now this was very important. Now initially we were talking about amiodarone, which was the first drug of choice when we talk about and as an antiarrhythmic. Now lidocaine has been given as an equal weightage. It has been given an equal weightage along with amiodarone. So naturally they can be used. Either of them can be used, and it is which is there in the recent guideline. And dopamine, of course, the doses have been changed. Emphasis. The other thing is IV access and ECG moved earlier in the algorithm, and the SPO to target has been now set in as 94% for stroke people. So that is something new. And the other thing, of course, has already been discussed by Tapesh very nicely. I don't want to go on this again in detail. And this is what was neuroprognostication. We need to go for an imaging. We need to go for electrophysiological analysis. We need to go for clinical examination and the serum biomarkers. Now, they are something which is very important for, and they have been incorporated to see whether the patient has a proper neurological outcome. This I've already said, double sequence defibrillation. I don't want to discuss more on this. I think this is what was total. It was in all about my discussion regarding the new things which was there. I think I can stop sharing my slide, and we can discuss if anything else would like to be discussed by a question. If there's any question amongst the audience, do you have any question, Tapesh? Hello. Tapesh, do you have any question? You're muted, I think. Tapesh, you're muted. You cannot hear me.
Yeah, can you hear me?
Yeah, we can hear you now.
So this double sequence defibrillation, how much energy we are giving in this?
Actually, we are giving 200 or 120. You can start with both the AED simultaneously giving with the pads, but this is not recommended now. This double sequence, because the studies have shown that it is not at all improving your outcome. So naturally, we are not giving that. Yeah.
So why this came up, sir? Because this is biphasic.
Yeah, this came up. Hello. This came up because there were some studies which they showed that it improves your outcome. There were the previous algorithm they had discussed on this, and there were a lot of studies on this with a positive result. But subsequently, when a control trial was done, they have found that it is not helpful, and it is in fact causing much more difficulties when we do go for an AED, double AED. Hello. Hello. Hello, Tapesh. Are you there? Anyone is there? Am I disconnectivity or what? I think we have crossed the time probably. Nee? Hello, huh? Yeah, actually, there was a disconnection, I think. Hello, can you hear me?
Yes, I can hear you, sir.
So naturally, as I said, that there were some positive results with this double sequential AED, but then subsequently it has, does not have any benefit now. The recent guidelines, they said that we don't need to go for it. It's not recommended at all. Yeah. There are around 40 recommendations in the recent guidelines, and the pediatric pregnancy, they're all there. And certain things which I would like to add is, one very important thing which I would like to highlight here is, right after your defibrillation, you should go for a cardiac massage. There could be a question. There is a question that why do you need to go for a CPR right after defibrillation? Why not check pulse? Why? Because
actually, when you are defibrillating, you have to establish the perfusion. So unless you establish the perfusion, you cannot check for the pulse, because defibrillation is not instantaneous. Perfusion does not come instantaneously. So you have to give the cardiac massage to maintain the coronary perfusion.
Yeah, actually,
if you stopping cardiac massage for just 3 seconds breaks the circulation. That you are well aware of.
Yeah, exactly. That is what is important. Actually, when you defibrillate an heart, primarily what you're trying to do is, when the heart is defibrillating, there are a lot of ectopic focuses, and the boss. If you talk about a boss, which is the SA node, along with the SA node, there are a lot of ectopic focuses. Now, SA node has a characteristic feature, that is, it has an automaticity. Whereas the other ectopic focus, which is there, they don't have that automaticity. What defibrillation is doing is, it is stopping all those small ectopic focuses. So it is stopping them, and as a result, the SA node, which has an automaticity, it is not going to stop. It will automatically take its automaticity and start beating. Now, the initial beating of this SA node is not at par to develop a good amount of cardiac output, to generate a good amount of cardiac output, because the initial contraction will be very low. So that is why, to expedite or to increase that cardiac output, we are going for a cardiac massage, so that the heart starts beating. But in addition to that, we give a support by compressing the heart, so as to generate a good amount of cardiac output. So that is why we don't stop after the defibrillation. We start giving cardiac massage. This is very specific on this.
Yes.
The other thing is, when do we stop CPR? Very rightly said, we stop CPR. And the other thing is, especially in an out of hospital or in hospital cardiac arrest also, when the person is doing a CPR, he gets exhausted. You have to keep that in mind, that whether I am getting exhausted, I must see that. So
it is quite tiring.
So naturally, if you are getting exhausted, you have to save yourself first. And the second thing is, when the patient's relative tells you that, sir, please stop CPR, we don't want. That means almost you can say it's a DNR situation. Please don't do on CPR. We have had enough. So that is what is. The other thing is one very important question that people, young students can ask: when do you say it's a refractory CPR? When do you say the CPR has become refractory?
Sorry, interactive or refractory I think one when there are 3 cycles of CPR and shocks, VT-VF is not broken. That is one refractory VT-VF.
Yeah.
And that is
exactly. So there are 2 conditions. One is when 3 subsequent shock has been administered, and despite that the patient has not turned up. One. Second thing is after 10 minutes of a CPR, continuous 10 minutes of CPR, the return of spontaneous circulation does not come, then you're going for a refractory CPR. Now the other thing is, very rightly Dr. Tapesh, you said that when you're prolonging your CPR, then you see the prognosis is better. The reason is, very importantly, there's a rider here. The rider is that when you're prolonging your CPR, you must see that the return of spontaneous circulation is there in between. If there is no return of spontaneous circulation in between, then the prognosis will not be good. But if supposing we have done a CPR for 30 minutes, and within the 30 minutes, the patient has come back with the return of spontaneous for 5 times, and it has gone back again. It has come for 5 times. I mean, every time it is going back. So that return of spontaneous circulation is trying to deliver some oxygen to the brain. So a person who's having a 30 minutes continuous without return of spontaneous circulation, his prognosis will be very bad than a person who's having a continuous 30 minute CPR where there is at least 2-3 times return of spontaneous circulation. There the prognosis will be better. So this is the rider there.
Yes, absolutely. Very nice. So I think, sir, any more comments, or I think we should close it now because it's 7:20. So thank you so much. So with your permission, I should close it now. And
thank you so much.
Thank you so much for your experience, sharing your thoughts and the research work and your slides. Thank you very much, Moied sir, for having been here with us and teaching all of us. Thank you so much.
Just 1 second. If I just want to see that whether this gentleman is there. If he's not there, probably we'll switch close up. I think that he's not there, I suppose. Okay. Thank you so much. Okay, dear. Bye.
Okay, sir. Thank you, Subha.
Thanks.
So thank you, Chetan. And thank you, Shipla, for providing the digital platform. Thank you, everybody.
Thank you. Okay, bye.